Okay, good evening, class. Welcome to our today's lecture on cephalosporins. Uh, by the end of this lecture, you should be able to define cephalosporins, carbapenems, and monobactams as classes of antibiotics. Describe the mechanism of action of cephalosporins, carbapenems, and monobactams, and classify different generations of cephalosporins and understand their spectrum of activity. List the measured indications for cephalosporins, carbapenems, and monobactams, and also be able to identify the contraindications and common adverse effects associated with cephalosporins, carbapenems, and monobactams. Let's get started. Cephalosporins are a class of beta-lactam antibiotics similar to the penicillins, both chemically and functionally. They are derived from 7-aminocephalosporanic acid through chemical modifications. Cephalosporins are structurally similar to penicillins but have side chains added to 7-aminocephalosporanic acid. These modifications create various generations of cephalosporins, each with specific properties and uses. So, the cephalosporins are actually modified penicillins, and they might be similar in most of their actions, except that we have created more modifications here such that the cephalosporins acts in a much broader spectrum as compared to the penicillin. So for this reason, you might not need to treat somebody who is already on cephalosporins with any penicillin-related medication, because otherwise already we are almost giving the same medication, and which is actually a narrower range. So cephalosporins are actually broader range compared to most of the penicillins. Classification, we say cephalosporins are classified into first, second, third, and fourth generations based on their spectrum of activity and also resistance to beta-lactamases. Each generation has different coverage against bacteria, with the later generations typically having a broader spectrum. So the first generation cephalosporins have a narrow spectrum of action compared to the second, and then the second have also a narrow spectrum of action compared to so the latest the generation, then the more broader the spectrum of action of these cephalosporin medications. Let's look at the first generation cephalosporins. These cephalosporins are effective against gram-positive bacteria and some few gram-negative bacteria. Okay, so what you need to know is that the first generation are mostly effective against gram-positives. They are often used as replacement for penicillin G and are resistant to staphylococcal penicillinase. So their actions are similar to those of penicillin G. So like we mentioned last time that some people have some allergies to penicillins, but perhaps cephalosporin can be a better replacement for that. Though sometimes also some people might have some level of allergy to cephalosporin, but it's not as much as registered, especially with the penicillins. They also show some kind of resistance to the penicillinase enzyme that is produced by the staphylococcus that makes it a bit resistant to penicillin treatment. So this cephalosporin first generation cephalosporin might be of benefit in treating this kind of infection as compared to when you are only using penicillin to treat staphylococcus alone. The second generation cephalosporins, these ones have increased activity against gram-negatives, bacteria like Haemophilus influenzae and Neisseria species. So here you see the second generation instead have more increased activity against gram-negatives as compared to the first, which were more of gram-positives, but only small action against some few gram-negatives. They are less effective against gram-positive bacteria compared to the first generation cephalosporins. So you can have a choice here depending on the gram staining of the bacteria you are dealing with. The third generation cephalosporins have improved activity against gram-negative bacilli, including enteric pathogens like the E. coli and also Serratia mercescens. They are often used in the treatment of meningitis and other serious infections. The fourth generation cephalosporin, here we have given an example, Cepifime. Don't worry about first, second, and third example because we have the next slide coming up with specific names of drugs that belongs to those different generations of drugs. So cephalosporin is an example of fourth generation cephalosporin here with a broad spectrum of antibacterial activity. It is effective against both gram-negative and gram-positive bacteria, including Pseudomonas aeruginosa. So you see here, the third generation has almost balanced power in dealing with both gram-negative and gram-positives. So the more we ascend the ladder, the more powerful they are. Let's get a look at this table. Here we are looking at the fourth generation cephalosporins. But also we have on the right here a classification with examples from the first up to the fourth and even the fifth, by the way. Now we have example, the first generation here, we have cephalexin. We know cephalexin, which is commonly in the market. Okay. Second generation, we have cefoxitin. Third generation, we have cefotaxime, including also ceftriaxone. I think is in the same range here. Fourth generation, we have cefepime, and then the fifth generation, we have the ceprarolin. Now let's look at their activities against gram negative and also their resistances to the beta lactamase enzymes and then distribution in CSF. So generally the first generation, most of them have low activity against gram negative, also low against the beta lactamases and also poor distribution in CSF. The second generation has higher gram negative activity, higher beta lactamases, but also poor penetration in CSF. The third generation have higher gram-negative activity, higher beta-lactamases, and good distribution in CSF. So if we are dealing with infections that involves the CSF, like in meningitis, that means really the third generation might be of better help because at least it fixes all these body compartments. The fourth generation has highest gram-negative activity, also highest beta-lactamase activity, and also good CSF penetration. The fifth generation is just the same as the fourth, so they are really equally important. Mechanisms of resistance. Bacterial resistance to cephalosporin is similar to penicillin's resistant mechanisms. Some bacteria produce extended spectrum beta-lactamases, which can hydrolyze cephalosporins, leading to resistance. So this is the mechanism through which, again, resistance can develop towards our cephalosporin. So no drug is safe. Bacteria always find a way to evolve and try to become resistant. So not even the cephalosporins are also free from resistance issues. Okay, so we have the extended spectrum beta lactamase producing organisms like the E. coli and Klebsiella pneumoniae poses challenges in the treatment. Let's look at absorption of these drugs. Many cephalosporins are not absorbed well when taken orally, and that's why most of these drugs occur as injectable. Otherwise, they may not reach the therapeutic levels in the bloodstream if ingested by the mouth because of gastric acid destruction in the stomach. Therefore, they are often administered IV. Okay, I already mentioned this, and also sometimes IM to ensure effective delivery into the bloodstream. CSF penetration, we have already seen this in the table. Okay, while all cephalosporins are absorbed well by the body, only few can reach the acceptable therapeutic levels in the CSF, as we saw already from the third generation, fourth generation, and then the fifth generation. Half-life and activity for cephazolin. This one has the shortest half-life. It has a short half-life of only 1.8 hours, but it's effective against penicillinase producing Staphylococcus aureus. It is commonly used as a single dose prophylactic before surgery, particularly for operations lasting less than 3 hours. You can also give additional dosages when the surgery is a bit longer. Cephalosporin's ability to penetrate bone makes it suitable for various surgical procedures, including orthopedic surgery. All cephalosporins can pass through the placenta, potentially affecting the fetus during pregnancy if administered to the mother. So we need to take precaution with this. Biotransformation and elimination. The cause metabolism of cephalosporin is not clinically significant. The kidneys primarily eliminate these drugs via tubular secretions or glomerular filtration. In case of severe renal failure, the dosage need to be adjusted. Otherwise, uh, it will lead to accumulation of toxic effects because of reduced elimination by the kidney. Ceftriaxone, however, is primarily eliminated in the feces through bile and is therefore referred in patients with renal failure. So you can see we have the best alternative here for patients with renal failure, which is ceftriaxone, because of its elimination in bile, not just through the kidney. Let's look at this table on biotransformation and elimination routes. We have the class of the drugs here, and then we have the example. So this table is important because it has given even quite a range of examples within the different generation groups with all their routes of administration, okay, and then even the major routes of elimination. You can see all of them are just renal, except here I mean, yeah, except here the ceftriaxone, which is a third generation cephalosporin, which we said is eliminated through hepatic route, and then the normal renal function. So you see, this is a renal function test that we can assess to correlate. This is the half-life of the drug, and then normal renal function and severe renal function impairment. So these are the figures. Okay, and these are comparisons that you can make. So you can coming to the names of the drug. See here the first generation, okay, cephadroxil, cephazolin, cephalexin, second generation, cephalclos, cefotetan, cefoxitim, cefafroxil, and then cefuroxime is also here. Third generation, we have quite many, cefatinib, cefadifluoren, cefixime, cefotaxime, we have Cefixime here. The first three can be given as oral, but you can see also the rest, most of them are IV. And then, yeah, the last one here is ceftriaxone, which is one of the latest in the group of cephalosporins. Side effects. Cephalosporins can cause various side effects, some of which may be specific to certain drugs within the cephalosporins class, but also including some allergies as registered similar to those of the penicillin. Some people have some level of allergy to cephalosporins as well. Contraindications. Patients who have experienced allergic reactions to penicillin, including severe conditions like the Stevens-Johnson syndrome or toxic epidermal necrolysis, should not be given cephalosporins. So for patients known to react to penicillins, we might have to be cautious and we may not need to give them cephalosporin because we talked about the derivative of cephalosporins as being from the basis of penicillins. There's a cross-reactivity link between penicillins and cephalosporin and estimated at 3 to 5% primarily due to similarity in side chains rather than the beta-lactam structure. Higher cross-reactivity is observed between penicillin and first-generation cephalosporins. Therefore, caution is warranted when prescribing cephalosporins to individuals who are known to be allergic to penicillins. Nursing implications for cephalosporins. Conduct a thorough assessment of patient's medical history, including any allergies or previous adverse reactions to antibiotics, especially penicillins. Assess renal and hepatic function before initiating cephalosporins therapy, as dose adjustment may be necessary in patients with impaired organ function. We saw this in our previous table, telling the different readings in impaired impaired and also normal kidney function. Monitor vital signs and observe for signs of infection or adverse reactions throughout the treatment process. Still, adverse reaction, sometimes they can cause gastrointestinal upsets, okay? Cephalosporins commonly cause diarrhea, altering the GI tract of the bacteria. We talked about the normal flora. So these are broad spectrum antibiotics. So many a times they have the tendency of altering the normal flora and also leading to diarrhea. Also, there is hepatotoxicity. Okay, it can manifest as a result of that, but also we need to be monitoring for dehydration because if already somebody got diarrhea from this treatment, that means there is an element of losing bodily fluids, so we have to hydrate. Immune system, secondary infections like oral flush, genital pruritus, and vaginitis may also occur, necessitating prompt reporting and emphasizing personal hygiene. Adverse reaction in the renal, we can induce transient renal test inhibitions and toxicity, characterized by protein in urine, blood in urine, hematuria, okay, and decreased urine output, requiring monitoring and reporting of abnormal changes. In hematologic, there is what we call hypoprothrombinemia, that is reduction in the levels of thrombin with or without bleeding. It's rare but sometimes occurs, particularly in vulnerable patients necessitating assessment for bleeding symptoms and possible vitamin K administration. We know that vitamin K is a drug that acts as an anticoagulant, so it can potentiate the effects of it can counter the effects of hypoproteinemia. Electrolyte imbalances may also result, okay, due to cephalosporins high electrolyte content. These are sodium, they have sodium contents. You know, you see ceftriaxone, you see most of them have electrolyte content. So because we are injecting, the level of electrolyte may also be imbalanced. Uh, Still with adverse reaction in the vascular system, there's what we call thrombophlebitis because we give these drugs as IV. So sometimes they cause venous irritation, okay, inflammation or clotting in the veins may occur, which is a recurrent concern, especially with the IV medications. Still with drug interactions, patients taking cephalosporin concurrently with nephrotoxic medications should be monitored for signs of kidney toxicity. We already mentioned this. Also, interaction with antacids should be taken at least 2 hours before or after cephalosporin to prevent interference with the absorption. So if a patient is taking some magnesium hydroxide or aluminum hydroxide tablets, antacids, maybe for treatment of dyspepsia, and at the same time is being treated with ceftriaxone, we need to at least give this allowance of 2 hours while administering these medications because it will interfere with the absorption. Histamine antagonists should not be administered simultaneously with certain cephalosporins to avoid reducing their effectiveness. Iron supplements may also inhibit cephadinir absorption, requiring administration at least 2 hours apart. So if you are using cephadinir, you need to see if this person is also taking iron supplements. If so, you need to keep at least a window of 2 hours apart between the two medications. Probenecid acid use with cephalosporin increase the risk of toxicity, necessitating close monitoring. Patients also should avoid alcohol consumption during and after cephalosporin therapy to prevent adverse reactions. So this is another important precaution here. Cephalosporins may interfere with oral contraceptive effectiveness, necessitating additional contraceptive measures while continuing oral contraceptives. So it's also important to take this precaution, otherwise they may uh, cause ineffectiveness in the oral contraceptive actions, and one might expect unwanted results just because you might think the contraceptives are effective, but already because you are taking them together with cephalosporins, it was an alternation and unintended conceptions might occur as well. Let's look at carbapenems. Carbapenems have a low susceptibility to beta lactamases. They are ultra-wide activity. They have ultra-wide activity against gram-positive cocci and also gram-negative rods, including some anaerobes. They are especially useful for infections resistant to other antibiotics, including those caused by Enterobacter. Therapeutic uses of carbapenems say treatment of hospital-acquired infections. They are effective in urinary tract, respiratory tract, skin, and soft tissue infections, osteomyelitis, septic arthritis, bacteremia, gynecologic, and intra-abdominal infections. They have limited usefulness in staphylococcal endocarditis and not recommended for CNS infections. Adverse effects of carbapenems, Pseudomonas aeruginosa may become resistant during the therapy. Allergic reactions also, especially in patients allergic to penicillin, occurs with people on carbapenems. They also cause the side effect of nausea, vomiting, and also diarrhea occasionally. Let's look at monobactams. For the monobactams, we said azithromycin is the common monobactam we know. It is resistant to beta-lactamases produced by certain gram-negative proteins. It has no activity against gram-positive bacteria and anaerobe, so this is typically more of gram-negative treatments. Mechanism of action, it interferes with the synthesis of bacterial cell wall, just like the penicillin's mode of action. Pharmacologic effect of monobactams, they are highly resistant to beta-lactamases. They are highly active against aerobic gram-negative bacteria, including Pseudomonas aeruginosa. They have poor activity against gram-positive cocci and also anaerobic bacteria. We look at the therapeutic uses of monobactams. They are substituted by aminoglycosides in the treatment of urinary tract. So, in the absence of aminoglycoside, we can use a monobactam, okay, for the treatment of urinary tract infections, lower respiratory tract infections, and also skin and soft tissue infections. They are also used for osteomyelitis, gonorrhea, gynecologic, and intra-abdominal infections. Often, they can also be used in combination with other antimicrobial agents. Adverse effects, gastrointestinal upset with possible superinfection, vertigo and headache. Okay, vertigo is like feeling a spinning movement in your head, but also you can feel headache at the same time. Sometimes it causes some rare kind of liver damage, okay, hepatotoxicity. Skin rash may occur, but no cross allergenicity with penicillin. Let's look at the beta-lactamase inhibitors. The best known is the clavulanic acid that we already mentioned. We also have sulbactam and also tazobactam. They are used in fixed combination with certain hydrolyzable penicillins. Normally, they are combined with penicillins. Pharmacologic effects most active against plasmid encoded beta-lactamases. They are not good inhibitors of inducible chromosomal beta-lactamases formed by Enterobacter and Pseudomonas. So sometimes they are not so effective, okay, when we use them for treating Enterobacter and also Pseudomonas. Therapeutic uses of the beta-lactamase inhibitors, they are combined penicillin to enhance activity against beta-lactamase producing bacteria, and their adverse effects, as we said, they are generally well tolerated, but also there is that potential for gastrointestinal upset, like the other um, cephalosporins that we saw. Okay, with this, we have come to the end of this lecture. Thank you for being with me, and bye bye for now.